I'm going to hand over to our colleagues Catherine and Rachel, who are going to share the improvement work that they've been doing, and really looking forward to hearing about it. Thanks.
Hello there, it's Catherine. So I think I'm going to go first and then Rachel's going to do her presentation afterwards. And Ashley's very kindly going to keep me online with my slides. So just as a little bit of an introduction, looking at delivering home first within South Tyneside and Sunderland. And as I'm sure you'll all be aware, the risk aversion can be really quite a challenge to delivering this. Just move on to the next slide there, please, Ashley. So what we were seeing was that, unfortunately, we were identified as one of the national outliers in terms of our use of Pathway 3. We were seeing very high demand on our care homes, and it was really starting to challenge the capacity within the care homes. Unfortunately, we got ourselves up to about a 97% fill of our care home beds. We were seeing a lot of new people coming into hospital and unfortunately being discharged to care homes as short-term placements, but a lot of those were being converted into permanent placement for those people. And as a consequence of that, we were seeing a lot less people returning to the place that they were being admitted from. So it felt like we were letting people down. We weren't enabling people to return home after they'd been in for their admission and their care with us in the hospital. We'll just move on to the next slide, please. So what we looked at was the 2 wards within South Tyneside General Hospital that were making the best use of Pathway 3. And they were both of our care of the elderly wards. So we spoke with the integrated discharge team, our team of discharge nurses and social workers, and asked for volunteers to work with us on a 3-month pilot. So we identified a discharge nurse and one of our very experienced social workers who agreed that they would go and work onto our care of the elderly ward for us. And the intention was to look at understanding why we were looking at so many people going into short-term placement, so many people going out of hospital on Pathway 3, where those conversations were originating from, and was there any way that we could make a difference? Was it a true reflection of the need, or were there opportunities to turn that around? So the starting point for us on that ward was that we had an average length of stay of 14 days. And the discharges broken down by pathway is what you can see there, with almost a quarter of people going into a Pathway 3 placement, which was really quite disconcerting because a lot of these people had come from their own home. Granted, with large packages of care sometimes and with really complex presentation, but they were living at home. Can we just move on to the next slide, please? So what did we do? So we decided a 3-month pilot would give us a good indication of can we make a difference. And we started with a very, very vague ask of those 2 members of staff to just go in there and understand. And it started with them attending the daily morning board round, just to understand who was in the ward, what were the needs, what were the conversations that were happening. And those 2 members of staff very much took it on their own shoulders and moved the project forward. Found that it was really essential to be refocusing the conversations, understanding from the person, not from the ward team, but from the person, what mattered to them, what did they need to be able to do to return home, what were their concerns, what were their abilities at home before they came into hospital, and working really closely with the individuals that were in those beds and with their family members. So what we were finding was that a lot of the decision making was happening by the ward MDT. And ideas were being planted into people's heads that maybe it was time to start thinking about more support. And I don't think we were really looking at a strengths-based approach to discharge at that point. And also during the pandemic, because we needed to move people out of hospital quickly, we had used care home beds. And I think there'd just been an adoption of that process a little bit too wide. So those two members of staff were absolutely implicit in sharing knowledge and experience of what would community facilities were available, what care providers could give, what the voluntary sector could offer to support people. But what we also looked at doing was supporting the ward teams themselves in understanding what was being asked of the paperwork. So the electronic patient record, how that fed through to the discharge team. So huge amounts of education, but building that trust with the ward team that they were able to ask questions. And the questions were being answered contemporaneously rather than having to make a point of contacting the discharge team and saving up those queries or potentially solving the queries themselves. We'll just move on to the next one, please, Ashley. So we did the 3-month pilot, which took us to February this year, and we managed to shave a whole day off the length of stay. We did actually get it down to 10 days just prior to Christmas 22, but that has bounced up a little bit. And some of that is a reflection of the complexity of the needs of the people that come onto our ward. But the big difference that we saw was the pathways that people were being discharged out on. So our use of pathway 0, where people were going out to the previous level of living, no health and social care support for that discharge, went up to 23% from 10% previously. We also saw a marked difference in the use of pathway 3. So when we started this project and looked at we looked at 12 months data prior to starting this in December, and our usage of pathway 3 was 24.5%, and we brought that down to 9%, which was absolutely phenomenal for the people whose discharge we were involved with. And what we also managed to achieve through having those conversations and understanding people before they became medically optimised or community ready, is that we were able to take off the length of stay for people on a very straightforward discharge, reducing that by 2 days in total. So hopefully giving a much better experience to the people that we were working with. We'll move on to the next slide, please. Thank you. So because of the positives of the pilot, we then worked with our integrated discharge team to look at how we rolled that out across the whole of South Tyneside Hospital. And in July this year, we aligned all of our discharge team to each of the inpatient wards. So currently, we have 2 care of the elderly wards, and both of those wards have designated discharge nurses and social workers, predominantly because of the complexity of those people. And the other wards have a mixture of social workers, home first practitioners, and discharge nurses, to varying amounts of commitment in terms of the time that we give to those wards, dependent on their needs. But the learning that we took from our pilot was the importance of relationship building. A lot of the ward staff had gone through a huge amount of change, and we saw an awful lot of new recruitment over the last few years. So building the relationships with those people, educating them as to how it all works in South Tyneside, but making sure that we had that trust and that engagement with the staff, that we could start to work more collaboratively with them. Looking at the discharge team would have the discharge conversations because they were the experts in that field, which allowed our ward teams to be able to concentrate on caring for people, and helping them to get to the point of being able to go home. We also are looking at increasing the focus on discharge to home. So the conversation has to be, why, if they can't go home, why? What is it that we need to do to support people to go home? But home first has to be our focus at all times. And there's been a huge emphasis on changing the conversation, not just with the ward staff, but also with the people who are in our inpatient beds and their families. Because we are discharging people much earlier in their process of recovery, people are going home much more vulnerable, but it's given that reassurance that we have the services to support that at a much earlier stage as well. And then if we can go on to this is my last slide. So progress so far, like I say, we only started the full ward alignment in July this year. I have to say that the figures for July and August, they weren't very positive. Unfortunately, our length of stay went up because we were running two different systems at the same time. And I'm being absolutely honest as I possibly can be with you, because it's not all a bed of roses at all. But thankfully, the figures that I've got through for September are looking really positive. We're really starting to see the benefits of embedding the new ways of working. We're seeing that the length of stay for people being discharged on pathway 3 is reducing. So we're seeing people going out much quicker, and especially, if that's a decision that is changing somebody's place of residence, it's important that we're able to facilitate that in a really timely manner. But what we've really seen, and obviously the hope that we'd wanted, was that we're seeing a really marked decrease in our pathway 3 discharges at South Tyneside, and a lot more people are getting the opportunity of returning home. We are seeing people going home with much larger care packages, much more intensive therapy input on pathway 1 because of the vulnerabilities. And we're incredibly lucky in South Tyneside that for a small number of people we can offer a short period of living care. And those living carers are there to help us to build up a picture of what the person's able to do in their own environment, away from the restrictions of an acute hospital, and back to the familiarity of what they have at home. And that's proven some really, really good outcomes for us, and for the people of South Tyneside. We're almost becoming a victim of our own success though, because we've absolutely saturated our care providers. So we are doing great at reducing the burden on our care homes, but we've given ourselves another challenge now to work through, looking at how we accommodate people's need for care, and how we take that next step forward. So it's very much a whistle-stop tour of what we've done in terms of our ward alignment, but hopefully that's given you a really good taste of what we can do when we're brave, when we start thinking outside of the box and start challenging ourselves. And we really did challenge ourselves.
Brilliant.
I think we've got the opportunity for any questions or reflections before my colleague Rachel takes over.
Thanks, Catherine, for that. Really, really interesting. Great use of data there in terms of measuring the difference. And really, really honest in terms of, the improvement stuff isn't always just upwards, is it? You know, the steps back as well as forwards sometime. We've got some questions coming through. So we've got a question here from Victoria. Victoria?
Hello. So I'm Victoria, head of patient flow at North Tees. Lovely presentation, thank you, because obviously we're all trying to toy with which is the best way to do things. Can I just ask, in terms of your P3s, what's your average length of stay on that, for those P3s on that ward area or that aligned ward?
On the initial ward, we're still bobbling around sort of 13 days. Across the whole hospital, I believe we're around about sort of 15 days from them being medically. That's from the point of them. 15 to 16 days.
So that's the point of them being medically not meeting the criteria to reside.
Yeah.
Okay. Thank you ever so much for that.
No
Thank
problem.
you.
Cheers.
Any more questions for Catherine? Catherine, I've just got one around the live-in carers. I haven't heard that any other areas. That's something that's new, and is that being evaluated?
It is. Local authority are taking the lead with the evaluation of that, but I understand that the initial evaluations are looking incredibly positive. We're even seeing a lot of people who are coming off the living carer project with no statutory services. So not only are we're reducing them down to, maybe a couple of times a day care, we're actually, a lot of people, once they've got themselves back into a normal routine, they're actually living independently.
Right. Wow. Perhaps that's something we could have back at another meeting. Hear the evaluation of that. That'd be great.
I think it might be good to bring Steph Simpson in there, because Steph is from our local authority, and we'll probably be able to give you a lot more information on that.
Oh, Steph, do you want to add to that? Hi.
Yeah, sorry, I wasn't prepared to bring this level of data to the meeting because I didn't know this was happening. But what I'm more than happy to provide to the group is the outcomes of our living care service. It's been incredibly successful. I do echo Catherine's comments in that I don't think we've had one person that's been in receipt of living care that has needed to have been lifted out of their home and put into a placement as such. The experience thus far of people in receipt of living care is either that they leave that service independent, or that they leave with a domiciliary care package. So yeah, we're really positive and lucky to have that as a discharge solution.
That's great, Stephanie. We'll link up with you after the meeting.
Yeah,
and maybe we can share something. Yeah,
I'll publish some information within the group just to give you an idea of volume and outcomes.
Great, fabulous, thank you. Are we handing over to Rachel now? Yeah.
Yep, if there's no more questions, then it's over to Rachel.
Can't see any more at the moment, but if any come up, we'll fill them at the end, Catherine. Thank you so much, Catherine. Rachel, hi.
Hi, I knew I should have gone first. Right. So just a little bit of an introduction about myself. So my name is Rachel Daurat. I've worked for the local authority for the past 22 years. 18 months ago, I was asked to take on a secondment with Sunderland Trust to look at how we can streamline discharge. So quite fortunate as a social worker background, being asked to come into the hospital to help with discharge, which I think just sort of gives some recognition to the trust that we really want integration, and we really want a balance between local authority and the trust. So just a few things about what we're trying to do in terms of embedding our transfer of care hub. If you're going to move on, Ashley. So prior to the pandemic, we had the hospital discharge nurses on the wards, as well as the social work team, working together to focus on discharge. Pandemic came, and then a lot of social workers were still on the wards. The discharge nurses were back into an IDT environment. Referrals were kind of done via computer, not seeing the patients. So very much not ward based. So as you can imagine, with any kind of change, trying to support teams to get back on the wards and present has had some challenges, but we're getting there. If we can move on, Ashley. So what we've done is we've enhanced our integrated discharge team for it to become what we call a transfer of care hub. So what we've got currently is we've got social workers with the discharge nurses. We've got a homeless reduction officer who is local authority employed, and he deals with any homelessness issues. And there's a very quick turnaround with this gentleman, so that role's proved absolutely vital. We've got Age UK who sit alongside us. We have a CHC hybrid nurse, which I'll explain a little bit more later. And we've also got a trusted assessor who works around the P3s. What we are planning to do over the next month is have an actual therapist sitting with us, a reablement representative and recovery at home representative who will deliver our discharge service from hospital, embracing home first and discharge to assess. So what we're trying to really refocus our home first principles, very much like what Catherine was saying around challenging the amount of P3s. We have at the minute, and Sunderland is, unfortunately, the numbers are really high in regard to P3s. And I think a lot of that's to do with education from the ward to start with, in terms of expectations that we give families. And what we need to get back to is getting social care and nurses together on the ward and having those challenging conversations with consultants and families. So discharge to assess, what we're doing is we are amalgamating our reablement at home offer via local authority and our recovery at home service as well, who have healthcare assistants attached. So those two teams will be able to assess at home on the day, hopefully the day that the person's community ready. They will see the person at home and then determine what service they need there and then. As opposed to currently, every single pathway 1 and pathway 3 go via social work. So in Sunderland, social work resource is this, but the demand is this. So what we're trying to do is get the right people, the more complex people who need a social worker, and the more simpler cases to be dealt with via our transfer care hub and out on the same day. If we move on, Ashley. What we also did is a piece of work which started as a 3-month pilot and has become, I think, 9 months now we're in, where ICB Altogether Better, which is an alliance in Sunderland, and myself have worked together to look at fast track funded patients who are on a P1, and we commissioned one particular agency who delivered the service citywide, and with over nine months we've discharged about 70 odd people home the same day or the day after they were classed as community ready, and we've managed to achieve, their preferred place to pass away. Prior to that, the demand upon our social care and domiciliary care was significant, and then those people may have remained in hospital for several weeks or have passed away at home without this service. So it's been really successful. So we're doing a much big piece of work now to look at any fast track patients, not just hospital discharge, but also in the community, of how we can get that support in quicker to support people at home. So that's all organised by the Transfer of Care Hub as well. If you can move on, Ashley. We've also got a CHC nurse as part of the Transfer of Care Hub. Nursing needs assessments and fast tracks during COVID moved from the wards doing those assessments down to the integrated discharge team nurses, and what we're trying to do is educate the wards to take that task back, as they're the ones who are actually looking after the clients, and then they see those people day to day. So in South Tyneside, the wards do their nursing needs assessments, and we want to get back to that in Sunderland. So our CHC nurse, she can she's training the wards to be able to undertake that task, but she can also sign off any fast tracks, so there's no delay in waiting for our ICB colleagues, for example, to make that agreement. That nurse can make it then and there, so that's really helped speed up discharge as well. Just move on, Ashley. We've also looked at, as we always say, what we want is a one version of the truth data, and we've done a lot of work around systems and how we can get an end of day report to reflect what the actual delays are, how many P1s have we really had, how many new referrals have we received. So we're doing a lot of work with our IT, and we have developed an end of day report that covers both South Tyneside and Sunderland, which is much more reflective of our situation than it has been in the past. And we're also moving to electronic referrals, which has freed up nurses, for example, who are having to do referrals to district nurses. Now we have an electronic referral, and that's really sped up kind of response. Move on, please. So what we're seeing so far is the work that we've undertaken to streamline processes has absolutely made it's much more effective, and it's really reduced time of lots of cumbersome processes that we have. The work still continues because it is heavily dependent upon local authority, and what's happened is local authority in Sunderland have gone through a restructure. So what we've tried to do is restructure our hospital social work presence to align with the discharge to assess process, where social workers will not touch your average P1s. And we've also created a care team within local authority who will focus upon the P3s. And what we really want to do is learn from Catherine's work in regards to what can we do around our P3s and have those challenging conversations. Appreciating Sunderland, unfortunately, is big, and we've only got a very small resource, but absolutely Catherine and I have competitive conversations all the time. We work closely and keen to learn from each other. Being one trust but two different local authorities has its challenges. If you can move on, please, Ashley. So Lund's been renowned for community beds. Last year, I think we had about 70 plus in the system, where we blocked beds in care homes to be able to utilise those for people waiting for a care package. So historically, we've always had a very strong community bed-based service. And I'm very, very keen to turn that on its head, and let's stop putting people in a bed whilst waiting for a care package to get them home, because we know that people may not then get the therapy, they may not then get the more enabling kind of approach, and the longer people are in a bed, risks of infection or people becoming more dependent. So we've tried to be brave and say no more beds. So we just have 2 units, which is our rehab beds in Icar and Farnborough, but being more flexible about how we use them. So if you have less P2s, why can't we, in urgent situations around flow, use those, but not to the point of 70 beds? We're talking about maybe 40, which has come as a bit of a culture shock for some people, but is absolutely the right thing for the person. If you could move on, please. So what we've learned from the end of life pilot has been, it's been an absolute success. We've significantly reduced delayed discharges. So we've gone from maybe someone waiting for a week to literally they go the same day or the following day that the community ready. And we've learned from that obviously concept's correct, and we need to then broaden that now. So we're doing a lot of work with the ICB to look at procurement, etc. And I've obviously already said about the CHC nurse and how that's been beneficial. If you can move on, Ashley. The main challenges for me working across local authority and health, and sometimes we can be very protective of our organisation. So I think having a system coordinator role that Catherine and I fulfil, I think has been really helpful to be more balanced and professionally challenge our organisations as what can we do better to help people and not have people stuck in hospital. The one version of the truth has also been really important, because as we know, everyone can look at some data, and we can then interpret it to our own agenda sometimes, if we're being honest. So we all signed up for that across local authority and health. Can we move on? Yeah, so professional challenge is healthy. We need to be if we don't challenge each other and we just continue doing what we're going to make the changes that we need to make, I think it's really, really difficult. That when we're in a time of surge, we can absolutely look at each organisation and say, well, you didn't do that, you didn't do that. And we really need to respect where each other are coming from. We've also done a lot of work with change management, really, and people have worked in such a certain way in such a long time that for me it's been quite frustrating, but absolutely know that it takes time for people to change and culture to change, and that's just going to continue the journey that we're on currently. But the way we're going, I'm really positive about. And I think that is it. Has anyone got any questions?
That's great, Rachel. Brilliant. It's trying so much.
Yes.
There's a lot going on, isn't there?
Yeah.
What I liked was that very broad MDT, and the real use of skills and that sort of integrated way, and then that very much that focus on home first.
Absolutely.
And you talk about, I heard you talk about community ready as opposed to discharge ready. So
yes.
it's a subtle but quite a significant mindset shift, that, isn't it?
And it's important to have the voluntary sector involved. So we absolutely, Age UK are our key partner in that as well, in those discussions for patients.
Brilliant. I know Victoria's got a question in the chat around, do you have a policy for the homelessness role and a job description that you could share?
We certainly can send some information, yes.
Yeah, that would be great. If you could send that to Ashley, we can make sure we can get that sent out. And then there was another question around a pilot. So is this a pilot? Are there any plans to roll out? And I think that's the lived in carer initiative. Is that going to be more mainstream, or is it mainstream now, or is it a pilot?
From the living care perspective, it's no longer a pilot, it's business as usual.
Great, brilliant, thank you. And Catherine's made a comment there that we're lucky to have a senior local authority team who are willing to try things that are different around home first, which is brilliant. It's that bravery that you were talking about, isn't it, to really think differently. Any questions for Rachel? No. Here. Don't see any questions. Can I just say thank you, Rachel and Catherine, really giving us something to think about it. Oh, Simon's got a question here. Simon, do you want to ask your question? It was just around, Simon, I think you're coming and going a little bit.
You managed to recruit for that?
Recruitment for the living carers was through one of our currently contracted providers. We were fortunate that they offered this service in other parts of the region where they operated. So as a local authority, we commissioned that with them, and they were in a position, because I know how difficult it is, to recruit such staff. But yeah, we were quite fortunate in the provider was already very up to speed with this service and had operated it, I believe, in parts of Yorkshire.
Great, thank you. Deborah, I think you've got a question here as well. So is the living carer only for a limited length of time, and is it available 24/7?
Yeah, it's available for up to 2 weeks. and it's free at the point of use, in the sense that the social worker will continue to work with the person and the care agency to have a plan beyond that fortnight. And the data that we've seen thus far is, yeah, we very much are able to formulate that plan. The information that the living carer can provide alongside the person really gives that very clear understanding of the level of need. We work it alongside solutions such as assistive technology and, of course, the third sector, and the social workers reaching out in terms of every community resource that would possibly help that person. And then, like I say, the person will then progress beyond that 2-week stage. Should there be eligible needs, they'll move into what's very evident, a proportionate and relevant level of domiciliary care. Because sometimes that's a major problem, isn't it, when you're discharging people from hospital? Like Catherine said at the beginning, risk-averse care package that as a local authority we need to reassess and scale down very, very quickly, because people are anxious about people moving back out into the community and not having the care and support that they think they might need as they're presented on a hospital ward. So the living care opportunity really gives us as social care the picture to genuinely understand that person's needs.
Brilliant. Thank you, Stephanie. I know you weren't prepared to
No,
answer
I
those
wasn't.
questions.
That's my
Really
fault,
helpful.
Suzanne. I
No.
wasn't around last week to prepare with your agenda and everything.
Oh,
So
no.
my apologies.
No, that's great. We'll look forward to getting that information from you.